Okay, thanks a lot. Hello to everyone from me too. I'm Mike Averkiou from the University of Washington, and in the next 20 minutes, I will be talking about contrast-enhanced ultrasound in medical treatment evaluation. Here is a short outline of what I plan to cover. I will have a very short introduction on contrast-enhanced ultrasound. Then I will talk about the basics of quantification with bolus kinetics. Then describe a technique for respiratory gating, show you some clinical results, and close with some conclusions. In terms of introduction, ultrasound contrast agents, as probably everybody knows, is encapsulated microbubbles of diameters 1 to 10 microns. They have either a surfactant or a polymeric shell that inside them it encloses a PFC gas, a perfluorocarbon. And with ultrasound, these microbubbles oscillate, as you see in this movie over here. They are delivered intravenously, and once delivered intravenously, they go everywhere in the vascular system. They are a true blood pool agent, and that means they don't diffuse in the interstitial spaces. They only stay strictly into the vasculature. Contrast agents are imaged with nonlinear techniques. I'm going to try now to describe with just a single slide how that is done. Ultrasound induces nonlinear bubble oscillations, and that produces harmonic components. This happens as early as an MI of 0.01. The microbubbles also may be destroyed by ultrasound at a mechanical index, MI, greater than 0.1. Also, ultrasound generates harmonics during propagation in tissue. This is what's being utilized to form tissue harmonic images. However, this happens at a mechanical index greater than 0.3. So if we insonify at a mechanical index of 0.1, the microbubbles are nonlinear scatterers, and they are not destroyed. There is not tissue harmonic component, and we have a bubble-only image. This is the basic principle with which we observe microbubbles today. Now I'm going to show you a couple of examples. This is perfusion imaging of liver lesions, and here you see what's called a contrast side-by-side. On the right side, you see the tissue image, and on the left side, you see the bubble image. So when I play this loop, you can see now the arrival of the microbubbles. And in the first 15 to 30 seconds, we see the arterial phase. That's the supply coming through the hepatic artery. And then later on, we see the portal venous phase. And then eventually, we see the late portal phase from 2 to 5 minutes. So if I was to play that loop again and stop it at a couple of times, you can appreciate that the very first arrival of microbubbles, they are arriving in this area here, which is the tumor, is a colorectal met. If I continue playing that tumor at some point, it's going to be quite hypervascular, hyperechoic. And if I continue playing this, when the portal venous phase starts, it will start washing out, and eventually this becomes as a black void into an otherwise perfused and bright parenchyma. So you see now it's washing out. Here is another example. This is a liver focal nodular hyperplasia, and we can all appreciate in this case the spoke wheel appearance of an FNH with a central scar and being hyperechoic in all phases. And on the right panel now, we see a hepatocellular carcinoma where we can see early arterial filling and slow portal phase emptying. This is the HCC, and you can see in the arterial phase it was very bright, and now it continues to be bright and washing out very slowly. And we want to be able to quantify these little changes. So typically, during therapy monitoring, the tumor therapy evaluation is done with the RECIST criteria, which is strictly tumor size. However, there are new antivascular therapies that they are mainly cytostatic, And thus, the current therapy evaluation criteria, they are not adequate. For example, we can have tumors that they may be responding but not shrinking at first, or we can have tumors that may be shrinking in size but they are not responding. CT and MRI may be used for therapy assessment, but certain disadvantages exist. For example, we have ionizing radiation in CT. Cost is an issue, availability, and clinical validation. Contrast-enhanced ultrasound offers an alternative method for tumor response evaluation, and it is very convenient that our agent is a blood pool agent, and it's also harmless, easily available, bedside, and quantifiable. So what are we trying to measure with contrast-enhanced ultrasound? We want to measure blood flow in the macro and micro circulation. And we also want to measure blood volume or vascular density in a region of interest in a tumor. Doppler ultrasound without microbubbles is unable to make these measurements because in the microcirculation we have very low flow velocities, and that's not possible to measure with Doppler. Contrast agents with indicator dilution methods, and I will explain that now, are suited for such measurements, but still some issues exist. And finally, there are two approaches for quantification. One is bolus injection for wash-in, wash-out analysis, and the other is infusion for distraction replenishment analysis. Today, and for the rest of the remaining of this talk, I will only talk about bolus injection and wash-in, wash-out analysis. By the way, for the people that are interested in reading some review articles, I have two suggestions here, one in European Radiology and one in Ultrasound. I happen to be a co-author here, but that's not the reason why I'm including them. I am including them because in both of these publications, there is a good literature review, so you can read up to the point of publication the other activity and the other research in this area. So indicator dilution, which is the technique with which we're quantifying, relies on injecting an indicator, a tracer, and following it spreading through the passage in the body. So we put in a delta function here intravenously, in our case is the microbubbles, and as this is propagating it through the lungs and the heart, it's spreading out, and eventually it's arriving in the region of interest. If this is a lesion in the liver, it's even spreading out more. It has been used extensively in pharmacology, and the important parameters that describe this is the flow velocity and the flow volume. We can adapt this indicator dilution technique for ultrasound contrast agents, and that's what I'm going to describe to you right now. So the technique is as follows. We administer microbubble contrast agent, just like you see in this schematic here. We collect a 60-second loop. Here is a loop of an adrenal cortical metastasis. Here is a metastasis. Here is a lesion in the microbubble side of the image. And we can draw a region of interest around the tumor and one around the normal parenchyma. From those regions of interest, we can extract time intensity curves, as the ones that you see here, and we can fit those time intensity curves to an indicator dilution model and extract the important flow parameters, which they are rise time, mean transit time, peak intensity, and area under the curve. A few more words about these quantification parameters. So the area under the curve is the area, just like it says, is the area under the time intensity curve. The washing time or rise time is the time it takes from 0 to the peak intensity. The peak intensity is this point there, and the mean transit time is the first moment of the curve. There are the so-called Stewart-Hamilton relationships where they connect these parameters with flow. For example, flow Q is inversely proportional to the area under the curve, and also flow Q is inversely proportional with mean transit time. Keep in time that rise time and mean transit time are proportional. So this relation also applies for rise time. Now, indicator dilution talks about indicator concentration. In our case, we don't know the concentration, but we know the image intensity. And in previous work that we have published before, we have shown that the image intensity is proportional, is linearly related with indicator concentration, in our case, microbubbles. And the important parameters that we will always be noting is the peak intensity, rise time, mean transit time, and area under the curve. Now, there are a few basic steps and precautions for contrast-enhanced ultrasound quantification. We need excellent bubble sensitivity and good tissue suppression. Tissue suppression means a perfectly black image before the bubbles arrive. So care must be taken to choose the right system that's capable of offering that. We also need to have an optimal MI for no distraction and a good 2D gain. We use a large dynamic range or compression to avoid signal saturation. We don't want the signal to be saturated because we're quantifying everything. And we want to avoid large doses of ultrasound contrast agents because those cause acoustic shadowing. Acoustic shadowing is when we have too many microbubbles and the microbubbles in the near field are not letting us penetrating in the far field. Now, the linearization scheme is also important, and please make a real good note here. We cannot use decibels. We have to use the absolute linear data. Then we use a curve fit model, and that may be a log normal, an LDRW, or anything. But please make sure that you are consistent with the model use. You must use the same model throughout the analysis because you cannot mix and match. And finally, we can derive the quantification parameter from the bolus model, just like I showed you in the previous slide. Now, often, motion due to respiration is messing things up. For example, that previous loop that I've shown you, you can appreciate with the breathing of the patient, the whole lesion is moving left to right. And so if we don't do any respiratory gating, the lesion changes shape, size, and location. And if you form a time intensity curve, it looks like the one here. So you have a lot of noise because you are sampling areas outside the lesion. With a way that we have published in the past, we can do post-processing respiratory gating. So this is the respiratory motion. This is the extent of the respiratory motion. For example, how much the diaphragm is moving. And you can choose to limit the respiratory motion by just thresholding and keeping only the frames at the same part of the respiratory cycle. And in doing so, you can see now that it's almost like this person is not breathing anymore. The lesion is staying in front of us. And so that means we can maintain the shape, the size, and the location. And if we form a time intensity curve, we get much nicer time intensity curves. This is a time intensity curve for the lesion, and this is a time intensity curve for the parenchyma. And for that, we can do a curve fitting. To be able to validate all of this, we used an ideal model for perfusion investigations, and that is a machine-perfused pig liver model. This is a pig liver that we get from slaughterhouse as soon as the animal is sacrificed, and is hooked up to this setup here where it's kept alive anywhere from 6 to 8 hours, so we can do this type of measurements, and we can see how good we can measure flow changes. So we can do bubble injections, and we can appreciate this very beautiful vascularity of this healthy liver, and we can see anywhere from the small vessels, from the large vessels to the smaller vessels, and then eventually draining into the hepatic vein, which is an indication that the microbubbles are traversing all the way to the microcirculation and returning. So we decided to do detailed quantification of the liver blood flow by varying the flow pump. This is a chance to actually mimic tumor changes, and confirming with contrast-enhanced ultrasound that we can actually see what I just described. We can form time intensity curves in the portal vein or the hepatic artery, depending where we do the injection, the hepatic vein, and the parenchyma, and we get beautiful time intensity curves. So by varying the pump, we can then see if our quantifiable contrast-enhanced ultrasound is able to detect those flow changes. This is the results, and without getting into too much detail, I show you here time intensity curves when doing in red a hepatic artery injection, and when doing in blue a portal vein injection. And the main take-home message, without going into too much detail here, is that there is 1/r relationship, just like the indicator dilution. For example, here you see normalized rise time, and here you see flow rate. So for the hepatic artery, which varies in these flow rates here, these are physiological flow rates that we also find in humans, we can see that the rise time is changing with flow rate as expected, and the ideal line is this dashed line here. And the same observation is also observed when we're doing an injection in the portal vein. Now, in the portal vein, since it's a much larger system, the flow rates, they vary from a few hundred to 1500, and again, we're still measuring the normalized rise time. Now, one side point here is that very small changes, anywhere from 4 to 18%, they're not measured, but larger than 25% changes, they're easily measured. And keep in mind that usually when we're having restructuring in the tumor due to the tumor progression or regression, then those changes are a lot larger. So in other words, yes, we can measure blood flow changes due to the tumoral changes. And now I'm going to show you a clinical example. This is a 78-year-old male with colon cancer, and he has a liver metastasis and no prior therapy. This is day 0 before chemotherapy begins. This is a grayscale image. And now I'm going to follow the procedure I just described to you. The tumor is here, and this is normal parenchyma. This red area here is the area where I use for respiratory gating. We don't have time to go into this right now. So you see the time intensity curve. This is when the agent arrives. This is at the peak of the injection. This is the arterial washout. This is at the peak of the portal vein. And eventually at the late phase, where the lesion has become a black void. So here is the time intensity curve at day 0. Then at day 14, after the first chemo session, again, this is a tumor. This is normal parenchyma. This is the time intensity curve. This white line tells you where we are. So here is at the peak of the injection. Even though your eyes don't see many microbubbles in the lesion, there are still quantifiable microbubbles in there. This is later on in the peak of the portal venous phase, and finally in the late phase where everything washed out. And again, the same thing now on day 60, which is the 4th chemo session. And here is the tumor, here is normal parenchyma. And again, you can see how the microbubbles are washing in and washing out. This is the peak of the portal venous phase, and this is the late phase. So if we collect this data now, and we make this plot where here we have time in days from the beginning of the therapy, and this is rise time and mean transit time in seconds. This solid line here is the rise time of the tumor. This solid line here is the mean transit time of the tumor. The dashed line here is the rise time of the normal parenchyma, and the dashed line here is the mean transit time from the normal parenchyma. So now, if we form this ratio, which is called washing time ratio, which is the lesion washing time divided by the normal parenchyma washing time. In other words, if we divide the solid lines with the dashed lines, we get these new curves here, where they both seem to settle around 1. In other words, the lesion and the normal parenchyma, they are, as the time is progressing during chemo, for a patient who is responding, they are approaching 1 because the lesion is behaving the same way as a normal parenchyma. So this is an example of how we can use quantification with contrast-enhanced ultrasound. Now, in closing, I'd like to say there are some limitations and unknowns. Microbubble dosing and handling is very important. Machine settings, there are differences from machine to machine. Signal saturation and acoustic shadowing, which I already touched on. 2D contrast-enhanced ultrasound displays only a thick plane and not the full tumor. So eventually we want to do this in 3D contrast-enhanced ultrasound. And this is already happening in various sites in the world. The arterial input function is unknown, and continuous remodeling of the tumor vasculature, including cardiac output changes due to chemocardiotoxicity, are making our life difficult. The drug effect on individual disease, every patient, every metastasis is different, and the response to chemo is very unique. So we have to be aware with that. And finally, patient immune response and drug resistance, they also have an effect on the curves that we are forming and I showed you before. So in closing, contrast-enhanced ultrasound it offers an excellent depiction of the tumor macro and microvasculature, as we saw from the examples before. Indicator dilution technique, i.e. bolus kinetics, lead to relative flow and relative vascular volume estimation. So we can compare how things are changing from session to session, or we can compare how things are changing between the normal parenchyma and the tumor. The time parameters, rise time and mean transit time, and also the area under the curve, AUC, are all inversely proportional to the flow rate, where the peak intensity is proportional to the vascular volume or vascular density of the image plane or of the whole tumor if we're doing 3D ultrasound. Finally, as we saw from the work that was done on the machine-perfused pig livers, contrast-enhanced ultrasound quantification can detect relative flow changes, which they are typically greater than 20% everywhere in the liver vasculature. With this, I have concluded my presentation, and I thank you for your attention. I suppose now it's going to be time for questions.
Mike, very comprehensive and very didactic presentation. Thank you so much. Can you hear me?
Yes, I can hear you.
That's excellent. So up to now, we did not receive questions from the audience, but the audience is cordially invited to pose questions. And could you have a look into the future? In 5 to 10 years, what will be the value of dynamic contrast-enhanced ultrasound analyzing time intensity curves? What will be the future?
Yes, that's a very good, very interesting question, looking into the future. Definitely, a couple of things have to happen. First, this has to be further simplified and be able to do it on all systems, on all microbubbles. As we all know now, in Europe, Asia, and in the US, we have SonoView, but also we have other microbubbles available. In Japan, we have Sonazoid, and in other places in the world, we also have Definity and Optison. So we need to establish that irrespective of our indicator, we're getting the same answer, and at the same time, irrespective of the system being used. But very importantly, though, we must even further simplify things and make sure we can do this in 3 dimensions. I foresee to be able to do a bolus injection and do a 3D capture of the lesion. In there, we have all the information of all the planes, because as we all realize, tumors are highly heterogeneous, and we can analyze that. We can take care of all motion because now we have the complete tumor, and we should be able to give to the clinician, whether that's first the radiologist and then the oncologist or hepatologist, a very simple answer whether somebody is or is not responding, not only at the end of all chemotherapy session, but ideally we would like to do this early on in the first 1 or 2 sessions. That way, if there are patients that they are not responding, changes to their regimen could happen early on, and so we would not wait until the end to realize that there was drug resistance or that specific regimen wasn't working. So those are some of the things I expect to happen in the next 1 to 5 years, as you stated.
Thank you so much. One more question, and perhaps the final one. What are the best targets? Which kind of tumors do you expect to be best evaluated by dynamic contrast enhanced ultrasound?
Okay. It looks like if somebody looks at the literature today, the lesion that's being quantified, the organ that's being quantified the most is the liver. And so looking at my slides now, I realize I only presented about the liver, and the same techniques apply to other organs as well. As a matter of fact, the liver has the peculiarity that has 2 inputs and 1 output, which actually complicate things a little bit. So, but nevertheless, we are able to do the liver because it's an easy target, it's a high vascular organ, and it's easy to see the lesions and to do these techniques. However, the same technique is applied to the kidney, to the prostate, to the breast, to the thyroid. So those are some lesions that people have addressed up to now, and you can find those and other things that I haven't mentioned. But it looks like at the present time there is more activity surrounding the liver.
There are 2 more questions from the audience. One is, how can we deal with the treatment-induced necrosis in lesions? Not the biological active,
Correct.
but the necrotic ones.
Yes. There are 2 ways of addressing that. If you are always placing your region of interest to the outer mark of the lesion, the lesion necrosis will not contribute towards the enhancement of the area. So either you can include it and you realize that your overall intensity is changing, but the time parameters probably are not changing, or you can draw a region of interest in the lesion that's not necrosed. In other words, you outline with your region of interest the non-necrosed lesion. So that is a very good and a very difficult question, because I wish I could give an answer specific that would be good for everything. However, what I do, typically I look at the lesion together with the radiologist, and we make the evaluation whether we're going to include the whole lesion, including the necrosis, or just do the ring around the lesion. Keep in mind that if you do the whole area, you are averaging the results over the area of the necrosis, but that's also important information. It's area without flow. Or if you are only interested in measuring the flow in the live part of the lesion, then you do the region of interest carefully around that area.
Thank you so much. There's one question from Dr. Alexei Borsukov, and he is asking, if we make the radiofrequency ablation of 2 metastases at one time, CEUS is made separately for each focus, or is it possible to cooperate these studies with evaluation only the portovenous and deferred venous contrast phases, where the arterial phase is rather short and you may evaluate only one focus?
I'm going to try and answer it if I understood it correctly. So is the intention to do contrast-enhanced ultrasound after RFA? So if it's after RFA, you can do this on a single injection, and it doesn't matter. Like I'm wondering whether when he says single focus, where to place the focus of the system. But typically, if you place the focus somewhere where it covers both, that should be okay. If that's what he means, if we can have them in the same imaging plane, then with the same injection, we can analyze that. But we can't just simply go in the late phase, because if we only go in the late phase, we might skip the arterial phase, and it's possible if we have a radiofrequency ablation that hasn't quite succeeded, in the late phase, it will wash out and it will show us a void. But in the arterial phase, we need to be able to see that there is no flow into the lesion. So I hope
that was his question, and you very nicely responded to that. Only in the arterial phase. So if we have 2 radiofrequency ablations not in one screen, we have to inject twice. Is that true?
Oh, yes, indeed. If we have 2 lesions in 2 different places, 2 different imaging planes, of course we can inject twice. But if somebody is using SonoView as we all know, out of a SonoView vial, we can easily get 4 injections.
Mike, thank you so much. That was great. A very
You're
good
welcome.
introduction into that very difficult subject. One more time, thank you very much. Big applause from the audience, which you cannot hear.
Okay, thank you. It's
Have a
my
beautiful
pleasure.
day.
Yes, thank you.